Hi, Dr. Centeno. Sorry I'm a couple minutes late here. Today we're going to talk about an interesting topic and one that's come up a lot in that digital motion X-ray or DMX is often recommended uh, in order for us to get to a diagnosis of craniocervical instability. But the problem is that DMX is not usually available in European countries, and or there are certain parts of the United States where DMX might be hard to access, etc. Now, many times, if you're in the U.S., we just can get a DMX when you come out to Colorado. Other times, maybe a little more difficult, right? We've got someone who's planning to travel halfway across the world, and we'd like to see at least some screening imaging to try to make sure that they're making the trip for a good reason, meaning they likely have craniocervical instability. So I'm going to go through again, like as usual, a quick, maybe 10-minute presentation or so. And then from there, you can ask questions about this topic or anything else. I've also put up a little guide for radiology techs. So once you get to the hospital, there's two parts about this. One is that you as the patient needs to understand how the imaging should be done. And then obviously the tech needs to understand it. So let's go ahead and start that presentation here. I'm just going to share my screen. Okay. So what to do if you have no DMX close by, and is there a workaround that would work for most CCI patients? Now, it's not going to be perfect, right? We sometimes rely on DMX, sometimes other things as well. But the goal here is to try to get it good enough for most patients so that patients aren't stressing that they can't get a local DMX in the UK or in some part of Europe or in some part of rural America before they make the trip here where they can easily get a DMX. So let's talk about what that would look like. So digital motion X-ray is DMX. That's a live video of the neck bones moving against one another while the patient performs specific movements. And it looks for excessive motion caused by damaged ligaments. So here, as I showed on Friday, this is C1, and this is C2, and this is the corner we're looking at when we talk about C1, C2 overhang. So can we get this kind of picture? Well, it won't be as good as DMX. Can we get it done at the local hospital? And the answer is you can get it done. So the good news about DMX is that it's better validated than most neurosurgical measurements. And what I mean by that is that in order to validate a neurosurgical measurement as being abnormal, we have to have studies that are done in the patient population that we're discussing, right? In this case, there are really two kinds of cervical instability patients or craniocervical instability patients. The most common kind understood by neurosurgeons are those patients in a severe trauma. They come in literally with their head hanging off, and imaging is done to try to see if emergency surgery is required. And that's where most of the neurosurgical measurements that we're relying on to diagnose craniocervical instability on things like MRIs have come from. They've come from that world. Where they haven't come from is the world that I'm usually dealing with, which is someone who may have EDS or been involved in some sort of trauma, who does have loose ligaments, the ligaments that hold on the head, but emergency surgery isn't required. And the nice thing about DMX is it's been validated in that population, the one that generally is asking these questions. Now, there are over 100 places to get a DMX in the US, but no Eurozone coverage for DMX. So is there a workaround? Can we use specific motions and positions in a routine hospital-based X-ray or clinic X-ray where we can get to good enough for most patients? And it's not going to be as good as a DMX because the nice thing about DMX is the motions go one direction, stop, and go the other. it's mostly going to be place yourself in that position and take a picture. But it may be good enough for us to be fairly convinced that that patient has craniocervical instability, and then we can follow up with the DMX once they get here if needed, and to make sure that it's worth it for them to take the big trip. So there's really two movements that we need. The first is maximum flexion and extension. The second is maximum side bending with an open mouth view. So flexion extension is literally just looking down and then looking back. And then the open mouth view, you're opening your mouth so that we can see the C1, C2. And then you're bending your head as far as you can to one side and as far as you can to the other side. Now, maximum flexion and extension, it's really critical that you go as far as you can possibly go. The biggest problem I see with these x-rays when I look at them is that the techs generally get in trouble, the radiology techs, if a patient reports that the tech asked them to do something that caused increased pain. Hence, they've learned through the years not to get the maximum range. What they generally tell patients is look down, look up, and they take the picture. That's not what we're talking about here. We need chin to chest, or as far as it'll go, and then head all the way back, or as far as that will go. So very, very critical that you get maximum range of motion here, even if you get pushback from the radiology tech. Radiology tech may not even know how to position the equipment to be able to track where your head and your neck is. And so they're going to have to make a few adjustments to make sure they get a good shot. But make sure that they know that your doctor is going to ask if you don't get flexion extension that's maximum, that this be repeated. So hopefully they will err on the side of trying to make less work for themselves and do it right. Now, what would happen if you didn't get maximum flexion extension? It just means at the end of the day, you may have instability, but we may not see it. And that's called a false negative. The patient really has the disease, in this case, instability, but because the test was poorly done, the test didn't show it. So that's why it's critical to get maximum range of motion here. And then we've got open mouth lateral bending, and that's the second part. So you're opening your mouth and you're bringing your head as far as you can to one side, ear to shoulder, and as far as you can to the other side, ear to shoulder. Now, the hard part about this is keeping everything in view, excuse me, while the patient's doing that. Not trivial, and it's not easy to do. So this may take a couple shots to get it correct, but basically the concept is that I've got to be able to see these corners here. As you can see here, here, and here. So we see C1 and C2. Again, just to recall, this is C1 and this is C2. But as you bring your head to the side, you're not turning your head at all. People do have a tendency to turn their head as they bring it to their side. So the head has to stay looking straight forward at all times while you're doing this. And on the side of the radiology tech, they've got to see these corners. So I put the basic instructions, and I'll probably go through and modify these a couple times here, so that you can go to a web page and basically bring it up on your phone if you need to while you're in there with the tech. And if you're not from the US, you need to translate it. That should be easy to do through Google. And the tech can read it and understand what it is we're looking for. So again, very important. Now, just the way this came in here, these three dots aren't there at the end. They kind of got inserted. They were supposed to be up here. So the actual URL includes up to this point here. So this is the URL. Go to that page, bring it up while you're in there with the radiology tech. You explain it to them now that you've looked at this video. They read it And then obviously the two of you should be able to get these films accomplished, and then we can take a look at them. And again, the goal here is to try to get a good enough amount of information where we can say, yes, this person, 99% chance they've got upper cervical instability or craniocervical instability. We may repeat the DMX when they get here, but I'm very comfortable with what I'm looking at, all without a DMX at all. So that's the goal here. Let me see if you've got any questions here. Okay, a bunch of different questions here. HRH, what is causing the vibration shaking in legs, body in CCI patients? Shaking in legs, probably the best way to look at that would be the concept of trying to lift weights on a boat. So for instance, if you're in a little rowboat and you were to try to lift kettlebells, that would be a very difficult thing to do, much more difficult than on land, because you've got no intrinsic stability in the actual boat, on your little rowboat. So you're going to shake and have all sorts of problems. So what we're likely dealing with there is upper cervical instability leading to those issues. HRH, I don't think I've got a good answer for that one. So I don't know the answer to that one. Submitted advanced by Harry Winston. Will this technique suffice for initial online evaluation? Yes, assuming we can get good films. I've designed this to try to make sure that I maximize the likelihood of finding craniocervical instability without actually having to get a DMX yet in someone who doesn't really have access to a DMX. Submitted advanced by Ramona Colby. Is it safe to do a DMX if moving your neck a lot causes serious exacerbation of symptoms for days? Well, it's definitely safe to do the DMX, but that's always obviously a positive negative thing that you've got to work out, whether it's worth it to you on the DMX side, meaning we can't get to a CCI diagnosis without imaging that supports it. So we're going to have to get that imaging one way or the other. The UK NHS spine consultants don't recognize, yeah, but that's all fine. You don't really need that at all. You don't really need any buy-in from the NHS here. All you really need is to get an X-ray. So I'd probably recommend going to a private clinic to get these X-rays, because my guess is they're going to work with you a little bit more than going to an NHS site, where I think you're going to probably struggle to get an NHS tech working for the hospital system to spend the time with you that'll be needed to get these images right. Sian, Maternal London has stated what ligaments are damaged in my neck, but they show abnormal readings on some. Yeah, I don't read the radiology reports very often. I think they've actually got a very good radiologist working there, but that's something I would look at directly. And MRI isn't the best way to determine which ligaments are damaged. We can certainly see signal changes in those ligaments, but until we see excessive motion associated with that signal change, it doesn't really mean much in isolation. Sorry, could you please recommend a cervical chiropractor in the UK? I'm thinking of going to London regenexx clinic, but I'm not from the UK, so I don't know what chiropractors to go to over here. I can't tell you a good one in the UK. You want to look at the NUCCA list and or AO list, but it looks like Phil has a good one for you right down here. So thank you, Phil, for that. When I tried turning my neck to the left, felt like I had something restricting it from turning in the front of my neck. Could that be elongated styloid stop me from doing that? Generally not. That generally would have nothing to do with an elongated styloid. And again, styloids don't elongate. The ligament that attaches to them calcifies. So there's really no such thing as an elongated styloid. There is a styloid that has its ligament that's attached, the stylohyoid ligament, that has gotten calcified. Sure, Anna. HRH, can you put the 100 or so DMX locations you just mentioned on your website? just like the instructions. I put the instructions there. On the DMX, I don't want to do that because we have certain DMXs that we think do a very good job and ones that are really hard to work with and do a very poor job. So it's best to go through Carla, my assistant, to try to get the name of a DMX place we've worked with here in the US that has done some really nice work versus obviously the ones that we can't seem to get to take a good image to save their lives. So very important to get a recommendation to a good place close to you. Connor, is a lax transverse ligament the reason why we look down through my skull, slide, and stop with a clunk? Certainly could be. When you look down, Connor, it's the transverse ligament that's preventing the dens from sliding backwards. So that very well could be. Can CCI cause brain fog confusion? Yes, Amy, that's in the CCI symptoms that I have online. So let's pull that up so that others can see those if they haven't already. Okay, I'm going to share my screen here in just a second once that comes up. So these are the most common CCI symptoms that we see in our clinic. And obviously brain fog is on here. So the bigger the word here, the more likely the patient is to report that symptom. So you can see the two biggies are headache, dizziness, lightheadedness. Then we go down from there. The next most common ones would be neck pain, numbness, tingling. And then we go down some more and we get into fatigue, cognitive issues, shoulder pain, brain fog, etc. So brain fog's pretty common in that whole list there. Daniel, my Centeno, my ADI is 8 millimeters on one side and 3 on the other from an upright MRI. Is this from alar ligament? Probably not talking about the same ADI as I would mean, meaning that ADI is generally means the distance between the atlas and the dens as you flex forward. I think you're meaning the distance between the dens and the atlas when you're in lateral bending. And yes, that could be due to laxity in the alar ligament, although again, upright MRI probably not the best way to get that information because we'd really want to see it, what it looks like in neutral and then left and then right and compare all that. Now, if they got a good upright MRI and they were able to keep you in a certain position long enough without you moving, then we could probably calculate it from the MRI. But the problem is it's going to be pretty hard to keep someone in that position of lateral bending long enough to get a really good picture. That would be better on this kind of X-ray that I just described, or on a DMX, obviously. What's the difference in measuring the overhang of C1 over C2 and side bending as opposed to measuring changes in the odontoid space? Yeah, so the answer is they're very similar measurements, but a little bit different, meaning that the changes in the periodontoid space, which is what Daniel is talking about, those will generally follow the overhang. Now, the only caveat to that is if it starts out where someone has a dens that isn't properly aligned in the atlas, then that generally won't follow the overhang. But certainly we look at both. So we're looking for an overhang and asymmetry in that periodontal space. What is Chiari0? Just got diagnosed with it. Yeah, I mean, Chiari0 is what about 20% of the population walking around out there has no idea they have any problems at all. So Chiari0 by itself doesn't really mean a lot. Now, Chiari0 in the context of craniocervical instability, in the context of symptoms, may mean more. But but by itself, not a real significant finding to be concerned about. Amy, is CCI same as Atlas not staying in place? Yes, Amy, that's the general concept behind CCI or craniocervical instability. Darby just had DMX last Thursday and started blacking out during the flexion extension portion. Could it have hurt me? I've been pretty flared up since then. Darby, I doubt it would permanently hurt you. That would be extremely unusual. And if it did, you really need more emergency surgery than anything. But certainly DMX movements can flare patients up for days or even weeks. But again, if you got permanently worse by doing that, then that's something you're going to need to have looked at as a surgical issue, because that means there's so much motion that it needs to be surgically treated. Anya, will DMX still be needed after this X-ray? If they don't have it in London Regenexx Clinic, will an upright MRI be needed, or just the X-ray enough? Again, Anya, this whole thing was designed to try to get enough information about craniocervical instability so that we could feel comfortable making the diagnosis long distance. Now, you still may need a DMX despite that, depending on the quality of the information we have, or you may not. When it comes to getting an upright MRI, you can always get an upright MRI, but as I've said before, if we look at each one of these types of images, a DMX, an upright MRI, or a routine MRI, the DMX is the most likely to see instability if it's present, then an upright MRI, then a routine MRI. Mike, is phonar MRI useful? Any opinion on Harshfield's radiology reports? Yeah, phonar MRI is great, and especially the way Dr. Rosa does his MRIs, in that we're getting a lot more information there. We're getting the cerebral spinal fluid flow. We're getting cerebral spinal fluid flow before and after an adjustment. So that's providing a lot more information than the average just upright MRI. CN, is it worth checking for Eagle syndrome? There's no way to check for Eagle syndrome, meaning that Eagle syndrome would be the concept that there's some calcification of the ligament that attaches to the styloid or the stylohyoid ligament, and that is compressing nerves, veins, etc. The problem is the only way to see if you've got clinical Eagle syndrome is to do a big surgery where we hack through the ligament that we're talking about, which helps to stabilize the front of your neck. So we need to destabilize the front of your neck to see if you have Eagle syndrome, meaning to see if your symptoms go away. So that's the difficulty there. What we frequently see is that we will see people who have Eagle syndrome type symptoms, and those are from craniocervical instability. Every once in a while, we'll see someone who has no craniocervical instability and does seem to be suffering from Eagle syndrome, but there is no specific diagnostic test that can be done that'll say for sure that if that you will respond to having the ligament removed. So ultimately, it's a little bit like skull-based decompression, right? Skull-based decompression, there is no surefire way to tell if that's what's causing your problem until we remove a piece of the back of your skull and see if you get better. Same thing with Eagle syndrome. So it's one of the reasons why you'd want to stay away from invasive Eagle syndrome surgery until everything else had been treated. Kelly, why do most neurosurgeons and neurologists not recognize CCI? Everyone that I've seen has no idea what I'm talking about. They tell me all my symptoms, which are exactly CCI symptoms, just anxiety, I have EDS, POTS, MCAS. Kelly, you know, most of the neurosurgery in this world meaning in CCI realm, is done by only a handful of surgeons, probably 5 to 7 US and international surgeons do about 70% of these procedures. So if you happen to see one of those 5 to 7 doctors, I'm sure they'd be happy to recognize and have an extended conversation with you about CCI and how that interfaces with HEDS, etc. But if you don't, then there's not a lot of expertise out there. So you're asking these guys to comment in an area that they just don't understand at all. And we doctors are really not good when we're backed into a corner by a patient on a topic we know nothing about. So I think that's what you're probably experiencing. But again, realize that there's only a handful of surgeons that do most of these surgeries worldwide. And if you don't get in that small group of surgeons, they're not going to know which end is up. Phil, what is your view on the value of CBCT and the cervical spine for analyzing CCI? I don't think it has a lot of diagnostic value for what it is we're trying to look at. Having said that, more information is always better than less. So when I see a CBCT, I will look at it, see if it fits with all the other puzzle pieces. But as a singular puzzle piece, can it diagnose CCI? Generally not. Samantha, I'm awaiting on confirmation of a teleconsult with you. I have extensive unavoidable hardware, C1 to T2, and I'm seeking care in a thoracic down. Really hoping to get to you in August. I can get to Europe for high quality images next week. Let know what imaging you prefer. Yeah, flexion extension, not so relevant. So it sounds like you're fused from C1 down to T2 and are having problems below T2. So really just the best MRI that you can get of the area below T2 would be the way to go. I really don't need flexion extension x-rays in the thoracic spine. And ultimately, a good chunk of the diagnosis and what will help is going to be based on physical exam as well. But the best image we can get would be great. And obviously the hardware is going to mess with the imaging. So we will try very, very hard to take a look at all that. But a lot of it's going to be on physical exam. Sian, the UK will never do these scans unless we had a DMX here. We're coming to Florida from DMX, then go back home. Yeah, I don't know if Florida would make sense. I think it's probably maybe less expensive, not sure. Probably the best thing to do would be to fly directly to Denver. A DMX can be done out here. You can also get a hands-on eval to see what's going on. It's probably, what, 2.5 hours more on the flight time. But it also may or may not be a little bit more expensive. That's something to look at, whether or not there may be cheaper, more available flights into Miami, Fort Lauderdale, Orlando, etc., direct from the UK. And that's something I don't know. But I think you could probably get more done with getting a DMX here, and then we can try to see what else is there. Meaning hands-on physical exam is a huge part of getting to what's likely to work. Just that having the imaging alone is helpful, but it's nothing like having the imaging plus a hands-on exam. Phil, does posterior PRP to cervical spine help restore lordosis? I don't think it helps restore lordosis by itself. I think it helps to support the lordosis. You still would need to get curve restoration. Dr. Joel Frank, a good surgeon, to see about this. He says he is, and he's in Florida. He's one of those surgeons around the country that does a lot of these kinds of surgeries. His claim to fame seems to be putting screws through C1, C2. I've not seen great results in most patients with that approach. The problems we've seen with that approach, the C1, C2 screw fixation, is that the non-union rate seems to be high, meaning C1, C2 should be growing together, but it doesn't. And misplacement of the screws can cause all sorts of problems. One lady, actually wasn't a lady, she was a young woman. She was actually a student at Stanford, had a screw placed too far in a C1, C2 screw fixation surgery into the 0-1 joint. So controlling the location of the screws in that surgery isn't trivial. So not a fan of the C1, C2 screw fixation type surgery at all. Anya, thank you for answering. Another question. After I cracked my neck, turn my head quickly to the side by pressing on my chin. It's less painful to swallow. What nerve, muscle, ligament is likely compressed? Yeah, it could be a lot of different things. Everything from the pharyngeal nerve which lives just in front of C1. In fact, here I'll see if I can bring up an image that looks like that, so we can take a look. Now, this was a blog I did on the internal jugular vein, but we will be able to have a similar location to look at. So so this is C1 here, and there's a transverse process of C1, and right in front of that transverse process of C1 is the internal jugular vein, but also the pharyngeal nerve and other pieces of real estate like the vagus nerve. So obviously, if C1 were displaced, you could have issues there. And then obviously it jumps back into place and the issues go away. Also realize that right in front here, there's not much distance between this area and the actual back of the throat and the muscles that control these things. In fact, in some patients, only a centimeter or less. So again, it's definitely something that makes sense with CCI patients and upper cervical instability. Beata, have you treated a patient with MCAS very reactive state? Yeah, Beata, I would say probably 2 out of 10 of our patients have been diagnosed with MCAS. So we've seen lots of different MCAS patients. Sometimes at their request, we've provided additional Benadryl IV or other antihistamines or other treatments IV. We've also worked with them on what it is we're injecting. So sometimes patients will come in beforehand, and if we're very concerned about even the components of what it is we'll use, we can do skin wheel testing to make sure that those components aren't going to cause a big reaction. But the most common thing would be our more severe MCAS patients requesting certain antihistamines be used during or after the procedure so that we can reduce the reactivity. Anya, about upright CBCT, Dr. Gillette in Barcelona diagnosis CCIA with this scan. Yeah, Anya, we've got different criteria for AAI and CCI than Dr. Gillette. I'm sure he's comfortable with that, and that's great, but we're not. So I don't think it's something that we are going to be able to get to. Now, if you've got CBCT with movement, that might be better because, again, that's just a little bit like the x-ray that we talked about earlier on, right? We can get an x-ray done in a hospital or clinic with specific instructions that will probably give us enough information, but that x-ray has movement with it, and we're looking to try to see if there's too much movement with this study. Okay, makes sense. Thanks very much. Samantha, would vertebral hemangiomas influence stem cells in the spinal area? No, vertebral hemangiomas, as far as we know, are just sort of normal variants of extra blood vessels that grow in vertebra. Duck, I have hypermobility syndrome and sprained my upper neck muscle attachment, suboccipital, PAOM. Surgeon ordered flexion extension MRI, which came back fine. Only symptom was bobblehead. Do I need a DMX? Well, Duck, if we're treating or trying to diagnose craniocervical instability, then you would need a DMX. If the thought is that all you did was to sprain those upper neck muscles, then those upper neck muscles would need to be treated through direct injection of platelet-rich plasma, either using x-ray guidance or ultrasound guidance. So it depends on what it is we're trying to treat there. Cian, how much you charge for DMX at Denver? We don't do the DMX. We've got a clinic that's close by that we will send you to that we know does a great job. I think they charge around $800 is my excuse me, sense of it, but I don't know their exact charges. But I think it's in that range, but we don't do them directly at our office. We've got such a good place near us that we've never put one in. Saved by grace. I have severe occipital neuralgia since after my 3rd fusion. Neck is all fused for years and now have CCI. I'm looking for ligaments fixed and C1C2 to be put back in line. They're tilted, rotated. Yeah, Grace, regrettably, with a fusion, that puts you into a different category. You've got what's called, sounds like, adjacent segment disease. And that means that the fusion is causing overload, in this case, of the upper neck. So regrettably, that's something we would chase. And what I mean by chase is that unlike the average patient, where we could fix that issue and get the ligaments to fully heal, in your case, because of the fusion, those ligaments will constantly be overloaded. So while we might be able to help, there is no fix involved. It would be chasing after the overload on a long-term basis. And what I mean by chasing after the overload would mean that you would probably need to be treated once a year, once every 2 years or so, to keep those upper cervical ligaments as good as possible and to keep the upper cervical joints as good as possible, including those nerves. But the problem is, that's one of the reasons why I always tell patients that, fusion at the end of the day is caveman medicine, right? We're making something that was built to move, not move. And once we make that decision, there's no way to turn that bus around. We now have a permanent overload happening above and below the fusion. So I think we can help, but not in the same way we can help some of these other patients that don't have fusions. Levon, is there a correlation between intensity and amount of symptoms in relation to the exact region of instability? For example, more symptoms when there's damage to C1 compared to C3. Not that I've ever seen at all. Intensity, amount of symptoms is related to where it is, what's happening, which structures are involved, the patient's own internal inflammatory chemical makeup, the sensitivity state of the local nerves. So more variables than almost that we can control for. How is a fusion fixing the damaged ligaments? A fusion doesn't fix the damaged ligaments. Like I said, fusion is caveman medicine. Now listen, it's caveman medicine that sometimes needs to happen because there's no other way to stabilize. What a fusion does is it stabilizes the area. The problem is that the area was built to move and be stable. So once we fuse it, meaning put hardware there, screws, bone, whatever, and it no longer moves, it's then going to overload the levels above and below. That's called adjacent segment disease. So at the end of the day, fusion does nothing to fix the damaged ligaments. All it does is a bad substitute for what the ligaments do, by, instead of allowing it to be stable with motion, by locking it down so there never is motion there again. Beata, thank you so much. Sure, Beata, happy to help. Phil, biomechanically speaking, how does the overhang affect the brainstem and cranial nerves, i.e. is causing ischemia of the blood supply to the brainstem, actual compression, distortion of the brainstem? Yeah, Phil, I think we covered that one over the last 2 weeks or so. So if you go back on the Facebook Lives on Mondays and Fridays, you'll see that I think I did one on how we can have brainstem irritation or compression of the trigeminal nucleus, and right there, that's on the sides of the brainstem with C1-ST overhang of a certain amount banging into the brainstem. So go back and look at that Facebook Live because it gets into that in some depth. HRH, how long after PICL will improvements be seen for a 3.8 and 5 millimeter overhang? Not quite sure that we can look at it that way, but I would say that that's still, for us, a moderate amount of overhang. So most of our patients would only do 1 or 2 currently, PICLs, in that kind of situation. And we wouldn't even look to about 4 months later to see if that really helped. Now, that's different for everybody, right? Some people heal more quickly than others. Some people have loose ligaments, so it might take longer to build up enough tissue to get better stability, all of that good stuff. Can you check at your clinic if you think the Eagle syndrome is an issue? I know down in one place they recommend removal, so the body have to keep on compensating on that side in the atlas and tilting. Yes, Ian, we don't recommend removal of any part of the body until there's until we've demonstrated that there is no other way to do it, meaning there is no free lunch. Once we remove anything, including the stylohyoid ligament, we are damaging the body's biomechanics. Now, hopefully, in the case where it must be removed, the overall improvement in patient function will compensate for the fact that we've permanently destabilized the anterior neck by removing that ligament. But there is no free lunch. Once you remove a ligament, you're permanently damaging the normal biomechanics of how things work. So again, never remove a ligament until you make sure that everything short of removing the ligament doesn't work. And that would include injection-based care long before someone destabilizes the anterior neck by yanking out the stylohyoid ligament. Duck was referring to the posterior issues only, not real CCI, where there's damage to the alar ligaments. The PO and suboccipital attachments have loosened out where my head feels heavy. DMX required. Well, DMX would be used to rule out instability in case you're wrong. So that's one thing. Obviously, in a hypermobile patient, that could be important. Another alternative way to approach something like that could be to treat those suboccipital attachments, again, with platelet-rich plasma and very precise placement into those specific areas that are damaged without the DMX, and see if that helps. Obviously, if it doesn't, you can always get the DMX done. Bonnie, is PRP effective in healing cervical narrowing? If so, to what degree? Bonnie, I think you're talking about cervical stenosis. So let's see here. Let's see, this might be a good one for you to look at. So this is a good blog at the regenexx.com site. So this is one to look up. You just go to the search bar and type that stuff in. Another good one to look at is my neck. I've got lots of cervical stenosis. And that would be something that's good to look at as well, because cervical stenosis doesn't really need to be opened up in the vast majority of patients. And those two blogs will discuss at more depth how that works and what's happening there. What's the minimum overhang that qualifies for CCI? It's 2 to 3 millimeters is the minimal overhang on a DMX. So if it's 2 millimeters, the chance of it being traumatic CCI is about 2 in 3 versus normal, just a normal variant. If it's 3 millimeters, the chances of it being traumatic CCI versus the normal variant is 95%. That's also when there's asymmetry in that periodontal space that we discussed. Daniel, can you inject just the alar ligaments when doing the PICL and leave the transverse ligament untreated? Sure, yeah, it's all doable. Cien, are the ligaments good as new after PICL? Is there a scan to see afterwards ligaments are back to normal? Cien, the goal of PICL would be to try to get your DMX to normalize, and that's something we routinely see happening, where we see dramatic decreases in, for instance, we're talking here about C1C2 overhang, so let's go with that, with C1C2 overhang. So that's the function of the ligament. As far as trying to look at the ligament structurally on MRI, again, as I said before, that's not really all that helpful, meaning we need to know how the ligaments function, and their goal is to prevent that extra motion or motion in end range, in this case, C1C2 overhang. So yes, that would be the goal of the procedure. And yes, there are patients where either they request to get another DMX, let's say on the overhang measurement, or we request it because we want to make sure that we are advancing appropriately, i.e. we can document objectively the patient's getting better. Anya, thank you. You wanted to ask how many rounds of PRP, pleural stem cells injection generally need to make a spinal and cervical instability better. If I have EDS, does it need to be redone after the instability's gotten better? For from people who had PRP in the back muscles that it works for about a year. Yeah, Anya, PRP in the back muscles would mean that they went to a place that had no idea what they're doing, meaning that injecting muscle trigger points in the muscles with PRP would be substandard care. If we're going to be injecting into the spine, normally that patient would be done until something else happens. As far as how many rounds of PRP proto stem cells, that depends on what it is we're treating, meaning that there's 100 diagnoses contained within your question. So I don't know which diagnosis we're treating there. Levon, what is your vision of PICL? What are you looking to modernize, improve, streamline in the very near future, improve the procedure outcome? Levon, I think we're pretty close to maximizing the procedural details. Obviously, we began this in 2015, trying just to use the tools available to us to try to get into these ligaments, and then that advanced to using 3D printed mouthpieces so that we could to expose the area we were trying to inject, endoscopy so we could see the area in the back of the throat that we're trying to inject and to maintain the sterile field. Then we went through a period of trying to define the best ways to inject these ligaments, because we were the only ones on earth to report injecting them. Then we had a dual C-arm fluoroscope, and that was probably about 4 or 5 months ago. And that has made a tremendous difference in the accuracy of getting where we want to be, and the hassle factor in getting there, and also reducing for the patient the time under anesthesia, which always increases the safety when procedures can be done more quickly and more accurately. So we're pretty good now. There might be 5% that happens over the next year or two to further dial in or this or that. I think that's going to be more, though, on the data acquisition side. And for instance, I just met with a research team today on taking another swipe at looking at whether or not EDS patients or patients without EDS respond any differently to PICL. And then going one step beyond that and looking at putting people into a couple of different categories like traumatic non-EDS, EDS, or predominantly autonomic, and trying to see if any of that makes a difference. So that's probably where most of the changes will come over the next couple of years. But I think the procedural components are very much 95% dialed in right now. Anya, I mean, should it be redone once a year as an example to keep stability? Not usually, Anya. If you've had good care, the answer would not be to treat you once a year. Usually what we're trying to do is to get you to a good steady state. And then once you're at that steady state, we shouldn't need to see you back unless something else happens. Stacy, I have a fusion from T4 to L4 for scoliosis, and I've been getting prolotherapy twice a year, which has mostly helped. The doctor sent me for PT for cervical stenosis, which mostly causes pain. I went for massage, and that seems to help along with working out. But I think most of my neck problems are ergonomic in front of a computer with a bad chair. Can you tell me what executive chair supports neck? Oh yeah, Stacy, that's so individualized that's a hard one to answer, especially if you're fused, right? Because if you're not fused, for instance, doing things like using a lumbar support pillow can really help align your neck, but that's if your spine moves. Without your spine moving from T4 to L4, that may not really move the needle for you. So that's such an individualized thing. I can't make any general recommendations there. Floyd, hi doctor, how do you know if a facet joint is responsible for dizziness or there's no arthritis on the CT scan? Well, Floyd, you know, facet joint arthritis is not something that necessarily would be associated with what we're discussing here. Let me see if I can find some pictures for you to show you what I'm talking about. So I'd look at this blog. Can you have serious neck injuries in a normal MRI? That was April 4th, 2022. And here's a good example here. Well, actually, let's go to a different one here. Okay, so these are some nice pictures here. So this is a study, an anatomic study done by some researchers in Australia, published about 20 years ago. And what they did is they took patients who had died of blunt abdominal trauma, and they then knew they, for instance, didn't die of a neck injury. They were able to take anatomic sections through things like facet joints. So here we see 3 different facets in 3 different patients. This one has bleeding into it. This one's got a bunch of blood in it. And this one has a fracture in it, including through the cartilage. Now, that's what a facet joint looks like under a microscope once we take an anatomical section. This is an MRI of the same facet joint. And as you can see, the first thing that hits you when you look at this, which is super clear, right? You can even see the individual trabeculum in the bone. You can even see the cartilage cells here. Versus this is a squintogram. This is what we see on a high field MRI when it comes to looking at that facet joint. It looks nothing like this. So if this facet joint had a tear in the cartilage, there's no way a radiologist would know at all. And a CT scan would be even worse than this. So a CT scan wouldn't be the way you would diagnose a problem in a facet joint. B, even if we had a high field MRI of that facet joint, it's unlikely that we're going to see what we want to see unless there is a lot of arthritis, meaning degenerative changes. So really those decisions are made on hands-on physical exam, where the doctor palpates each and every joint and looks at the symptoms versus the patient versus what that joint produces. But again, this is what it really looks like. And this is a high field MRI of that same structure. Very detailed. This looks like I lost my glasses, and I'm seeing this blurry thing. So just realize CT scan would not be something that we would consider a diagnostic tool looking for facet joint problems in the vast majority of patients. How many locations are injected along the alar and transverse ligaments during a PICL? It's all determined by flow of contrast. So meaning if the contrast flows more, then fewer. If the contrast doesn't flow where we need it to go within the ligament, for example, then we've got to inject more sites. Do we have to set up telemed for you to review my imaging? Yes, Jan, that's something I definitely would recommend. Duck, okay, thanks. I was actually thinking about getting posterior PRP done at your clinic to get quality PRP. Would you be able to try those before getting DMX to rule out damage to the front ligaments? Duck, I forgot which question is here. Those are old man problems, but let's see here. I was referring to the posterior tissues only, not real CCI. Oh, yeah. So if we're trying to see if those particular structures are injured, that would be hands-on physical exam. We could also do ultrasound imaging in the office. Obviously, if they need to be injected, they could be injected. Anya, how many rounds of injections is needed to treat spinal instability, including cervical, thoracic, lumbar instability? So I assume it's PICL plus PRP, posterior spinal ligaments and facets. I've heard that people get 3 to 4 rounds over months apart to get better. Yeah, I mean, it depends on what we're treating, but yes, in general, that sounds about right. Okay, guys, any other questions I can answer? And while we wait to see if there's any other questions coming in, just to review, so what we're talking about today is trying to get a X-ray when a DMX is not available. And we went through all of this stuff, but I'm going to try to share my screen and pick up that web address again here. That's not working. Yeah, guys, I don't seem to be able to share that one right now. Well, I guess I could just share the screen in general and bring it up. So anyway, this is the web address. It's right here for getting instructions for a radiology tech to be able to take some simple x-ray views that can try to mimic as best we can a DMX so that we can take a look at those. So for instance, if you're in the UK NHS, you may want to go to a private clinic to get this done, or if you're in another country, go to a private clinic to get these x-rays done. The instructions are there. And if you want to know what you should do on your side, then go ahead and take a look at the front of this video where that's explained. Doc, for posterior PRP at the POM, nuchal ligament and subaccept muscles clinic, are you and Dr. Schultz and the doctor should inject those at your clinic? No, that can be done more widely by other doctors in the clinic. So the only thing that Dr. Schultz and I focus on is doing more of the PICL part. Bonnie, do you have different options for the contrast to use? I seem to be very sensitive to it. Bonnie, we could certainly test you with different types of contrast, visipaque versus omnipaque. But if you're talking about sensitivity to contrast, just make sure you're not discussing things like IVP contrast for kidney disease or renal problems, because that's a totally different animal. Duck, for posterior and PRP, yeah, I think I answered that. Okay, guys, so it's 2 o'clock. I'm going to drop off here. Thanks so much for listening. Again, tried to provide some information so that you could get a routine x-ray done to try to substitute for a DMX when a DMX just isn't possible. And really the goal was to try to help our European patients, because we've had this asked a lot. Can I get something done here locally that you can look at that might be helpful in making this diagnosis? And the answer is yes. So there's some instructions for the rad tech that are on the regenexx site. And there's also instructions for you at the beginning of this video that goes into depth about what you should be trying to instruct on the rad tech side. So the two of you are working together to try to get these images. So thanks so much for watching. I will be here on Friday. And so I will see you this Friday, and everyone have a great week. Thank you.